You're welcome to this session. During this session, we shall be talking about preterm labor. My name is Adetunji Oladeni Adeniji. I'm a professor of obstetrics and gynecology at Ladoke Akintola University of Technology and also a consultant obstetrician gynecologist at the Ladoke Akintola University of Technology Teaching Hospital, Ogbomoso, Nigeria. During this session, we shall be discussing preterm labor, and at the end of this session, learners are expected to be able to define preterm labor, the risk factor, clinical assessment, physical examination, and preliminary investigation. Should be able to also discuss the role of alpha hydroxyprogesterone used in preterm birth, interpret on introduced clinical application of some investigation like fetal fibronectin, transvaginal ultrasound, be able to discuss the use of tocolytics and role of magnesium sulfate in preterm labor, as well as the use of non-steroidal anti-inflammatory drug as tocolytic in preterm labor, and what are the essential factors to consider in the use of non-steroidal anti-inflammatory drugs. What do we know as preterm labor? Preterm labor defined simply as the presence of uterine contractions of sufficient frequency and intensity, leading to progressive effacement and dilatation of cervix prior to term gestation. Term gestation is taken in this context as 37 completed weeks of gestation. There is a very high risk of preterm delivery when there is preterm labor with attendant complication. It suffices to say, not all cases of preterm uterine contraction leads eventually to preterm delivery. But in those which progress into preterm labor, it has its attendant complication. And this complication can be a lot of burden onto the mother and the family, both psychologically and financially. What are the risk factors here? The risk factor that predisposes a woman to subsequent risk of preterm labor are previous preterm deliveries, preterm premature rupture of fetal membrane, cervical incompetence, cervical surgery, or even uterine anomalies. Other risk factors include multiple gestation, polyhydramnios, placenta abruptio, vaginal bleeding at any time during the index pregnancy. Underweight mother, especially mother with pre-pregnancy weight less than 50 kilograms. Maternal infection, including genital or urinary tract infection. Chronic illness in mother, hypertension, diabetes. One of the habits, smoking, illicit drug use, or even physical or emotional abuse are risk factors for preterm labor. How do we make clinical assessment of a patient with suspected preterm labor? Detailed clinical history is essential, in which the medical, surgical, and obstetric history are explored in clear details to exclude or establish the risk factor earlier mentioned. So what are the signs of preterm labors? Lower abdominal cramping, pelvic pressure, lower back pain, vaginal spotting or what we call show, where you have mucoid discharge mixed with blood, or regular painful uterine activity associated with cervical changes, which are effacement and dilatation, are some of the things that points to preterm labor. When clinical examination are conducted, abdominal examination is very critical and crucial, because that is how you will be able to establish that uterine contraction is in process. Also, vital signs are also important. Investigation that can be done initially include things like midstream urinalysis, midstream urine for microscopic culture and sensitivity, fetal heart rate plus or minus cardiotocograph. And we need also to do sterile speculum examination to exclude premature rupture of fetal membrane. Now, if facilities are present, one can also do fetal fibronectin test. However, it is not in all cases of preterm labor that fetal fibronectin tests are applicable. In fact, it is contraindicated in 4 conditions. When you have a term gestation, it is superfluous to be doing fetal fibronectin tests. If you have rupture of fetal membrane, confirmed rupture of fetal membrane, it is not of clinical importance doing fetal fibronectin test. If you have antepartum hemorrhage or cervical dilatation greater than 3 centimeters, which in most instances equates to active phase of labor, you wouldn't need to do. In fact, fetal fibronectin test is done where the diagnosis of preterm labor is inconclusive. So, in all these 4 conditions, either because of the emergency situation it presents, or the fact that there is no need in waiting anymore, fetal fibronectin test is not advisable. A high vaginal swab for microscopic culture and sensitivity can also be done in suspected case of preterm labor, or low vaginal anorectal swab for group B streptococcus, which can complicate even delivery by predisposing to endometritis, can also be done to exclude and manage situations when you may come down with some other sequelae. In a case that are presented with preterm labor, one need to assess cervical dilatation. If rupture of fetal membrane have been excluded from our history and examination, and vaginal delivery is not contraindicated from the patient's condition, sterile digital vaginal examination can be undertaken. So, 2 conditions that will make sterile digital vaginal examination not to be applicable in this condition, in this case of a patient, are rupture of fetal membrane or suspected case of placenta previa. Transvaginal ultrasound also can be done when fetal fibronectin is negative or not available. How do we interpret the result of fetal fibronectin or transvaginal ultrasound? When the fetal fibronectin is positive, it is an indication of high risk of delivery within 7 days from the time of presentation of the patient. In this instance, one would need to adopt a 3-step approach, which I refer to as ATS. A means admit or transfer patient to adequately staffed facility. T means you may want to use tocolysis if not contraindicated. And X means steroid for fetal long maturity if estimated gestational age is less than 34 weeks. Now, positive fetal fibronectin with transvaginal ultrasound cervical length less than 2 centimeters. We need to admit such patient. We need to administer analgesia, steroid, plus or minus tocolysis in the event that, don't forget, we are dealing with premature labor, in this case, preterm labor, preterm labor. Now, what is the role of alpha hydroxyprogesterone use in preterm birth? A patient with history of spontaneous preterm birth in previous pregnancy, and this preterm birth between 16 weeks up to 34 weeks of pregnancy, or a patient with result of transvaginal ultrasound between 16 weeks and 24 weeks of pregnancy, which shows cervical length less than or equal to 25 millimeters, requires alpha hydroxyprogesterone use to prevent or minimize the risk of preterm or premature labor. This is as recommended by NICE guideline in 2019. It is not only vaginal pessary that are used. In some instances, you can use intramuscular alpha hydroxyprogesterone 250 milligrams weekly till 34 weeks. It is important to note that 34 weeks appears to be a magic week in obstetrics. Most patients with complications in pregnancy from 34 weeks and above, obstetrician tilt towards delivery than conservation. If we have negative fetal fibronectin, it suggests that there is a low risk of delivery within 7 days. Fetal fibronectin is a measure of the risk of delivery within 7 days. So negative fetal fibronectin is a reflection that the risk of delivery of that patient within 7 days is lower. And if this is coupled with transvaginal ultrasound of less than or equal to 2 centimeters cervical length, one may be tilting towards diagnosis of spurious or forced labor, especially if there are no continuing uterine contraction and there is no cervical change. So if no painful contraction ensues after observation, no regular contraction after 24 hours of observation, such a patient can be considered for discharge and advised to present if there are supervening conditions thereafter. If there is painful regular uterine contraction, even with negative fetal fibronectin, such patients need to be admitted for observation. Especially when there are no cervical changes, we can administer analgesia. Narcotic analgesia in this instance is often preferred, either petidine or pentazocine. And you review patient after 2 to 4 hours. If painful contraction persists, then we can consider more analgesia or tocolytics with steroid in anticipation that labor can proceed and delivery can occur preterm. It is noteworthy to know that the positive predictive value of a positive fetal fibronectin test or a short service alone is poor and should not be used exclusively to direct management in the setting of acute symptom. What this suggests is that the symptom supersede the findings of positive fetal fibronectin or short cervix in taking a decision whether you are admitting, whether you are discharging, whether you are given analgesia, or whether you are doing tocolytics. And this is in line with ACOG Practice Bulletin 171 of 2016. Now, using tocolytics in premature or preterm labor, the tocolytics that can be used include beta-2 agonist, calcium channel blocker, non-steroidal anti-inflammatory drug, or magnesium sulfate. What is the aim? The aim of tocolytics are purely two: is to suppress uterine contraction and delay preterm delivery in order to allow in utero transfer to appropriate level facility in the event that the facility she had presented to is unable to take and manage preterm delivery. It also allows for period of time to administer corticosteroids towards promoting lung maturity. So, but in using tocolytics, there are contraindications. If the gestational age is greater than 34 weeks, or labor is too advanced, or there is an intrauterine fetal death, tocolytics are contraindicated. Other conditions that will not allow for the use of tocolytics include fetal anomaly considered incompatible with life, as well as suspected fetal compromise, just like intrauterine growth restriction, abruption placenta, suspected intrauterine infection like chorioamnitis, or maternal hypotension, blood pressure less than 90 millimeter mercury systolic. In this condition listed, tocolytics is not advisable as a line of management. We need to also discuss what is the role or what are the roles of magnesium sulfate, especially as a fetal neuroprotection. Magnesium sulfate administration pre-delivery reduces the occurrence of cerebral palsy when given with neuroprotective intent. It is also can be given as a tocolytics. And when it is given as a tocolytics, it is preferably given as intravenous, by intravenous route, where you first give 4 grams intravenous, diluted up to 20 minutes and given over 10 to 15 minutes, slowly. And thereafter set up an infusion of magnesium sulfate 1 gram per hour, according to Sussman regimen. There is no demonstrable significant pregnancy prolongation when magnesium sulfate was given as a neuroprotection. In fact, the effect of magnesium sulfate being a tocolytics is between 24 to 48 hours. So magnesium sulfate reduces the severity and risk of cerebral palsy in surviving infant if administered when birth is anticipated before 32 weeks gestation. What is the role of a non-steroidal anti-inflammatory as a tocolytic in preterm labor? And in this instance, we are talking of indomethacin as tocolytic for pregnant women. It is most effective when used in gestational age less than 30 weeks. And this is premised on the fact that the inflammatory response in the membrane and decidua in pregnancy is very, very prominent at 30 weeks compared to 30 to 36 weeks. So gestational age less than 30 weeks, indomethacin as a tocolytic is very effective, especially when there is a pregnancy associated with polyhydramnios. When indomethacin is given, it readily crosses the placenta and can reduce the volume of the amniotic fluid by decreasing fetal renal blood flow, especially if used more than 48 hours. So, now, usually, the use of indomethacin as a tocolytic, and especially in polyhydramnios, is limited to 48 hours period. And the recommended dose is 100 milligram per rectum as a statum, and thereafter 50 milligram per hour 6 hourly to a maximum of 8 doses. If oligohydramnios occurs, the amniotic fluid restores itself when the indomethacin is stopped. So the fear is not unless if there are other renal pathology in that baby, especially when you have renal cysts and other renal lesions. So some of us, we are aware that indomethacin can cause premature closure or constriction of the ductus arteriosus. But this is more prominent in gestational age above 32 weeks. So, indomethacin as a tocolytic is recommended below gestational age of 30 weeks. So, it should not be used because above 30 weeks because of the risk of premature closure of the ductus arteriosus. So, it is not recommended for use after 32 weeks. What are the recommendations and conclusions from all this discussion, especially using consistent scientific evidence? A single course of corticosteroid is recommended for pregnant women between 24 weeks and 34 weeks of gestation who are at risk of delivery within 7 days. Fetal fibronectin positive. Magnesium sulfate reduces the severity and risk of cerebral palsy in surviving infant if administered when birth is anticipated before 32 weeks of gestation. And third, the evidence support the use of first-line tocolytic treatment with beta-adrenergic agonist therapy or calcium channel blocker or non-steroidal anti-inflammatory drug for short-term prolongation of pregnancy up to 48 hours to allow for administration of antenatal steroid. Maintenance therapy with tocolytics is ineffective for preventing preterm birth and improving neonatal outcome and is not recommended for these purposes. So our use of tocolytics is towards giving optimum neonatal outcome by administering corticosteroid or transferring this patient to a better facility. Antibiotics should not be used to prolong gestation or improve neonatal outcome in women with preterm labor and intact membrane. Antibiotics is only recommended when there is associated rupture of fetal membrane. Thank you for your attention.